Welcome to section 1 of renal pathology. In this section, we'll be discussing acute kidney injury. This is a super important topic to understand, and it can seem complicated, but we're going to totally demystify it in this video, and I will show you how you will be tested on this material using questions throughout. Now, acute kidney injury, or AKI, used to be called acute renal failure, and you may still hear acute renal failure sometimes, but that term has largely been replaced by acute kidney injury. Now, acute kidney injury is the abrupt decline in GFR, and it's important to know that creatinine clearance is used as a surrogate measure for GFR, because creatinine is not reabsorbed after it enters the filtrate, and creatinine is easier to measure than GFR. And I say it's not reabsorbed, but it's mostly not reabsorbed. In other words, it's treated as though it's not reabsorbed in the tubules for the purposes of trying to estimate GFR. Now, don't kill yourself trying to figure out that idea right now. If you need to, you can review that material in our renal physiology chapter. All you need to know for this discussion is that an abrupt rise in serum creatinine indicates acute kidney injury and decreased GFR. This decline in renal function naturally leads to the accumulation of waste products. So patients will have increased BUN and creatinine. The rise in these two substances in the serum is termed azotemia. Now, this abrupt decline in GFR also implies decreased urine output, or oliguria. And sometimes oliguria is not present, but it's typically present with acute kidney injury. There are three broad categories of acute kidney injury. There's prerenal, intrinsic, and postrenal. Here's the best way to think about this conceptually. Normally, blood enters the kidney, then the nephron filters the blood, and then the urine is excreted. Prerenal injury is caused by any issue in getting the blood to the kidney. Intrinsic injury is any defect at the kidney level, more specifically, an issue with the intrinsic functional unit of the kidney, which is the nephron. Now, postrenal injury is caused by anything that prevents the urine from exiting as it should. This table covers the different types of acute kidney injury. There's prerenal azotemia, postrenal azotemia, and intrinsic azotemia, which we've divided into two groups, those involving tubular damage and those involving glomerular damage. And we'll be covering the etiology and the lab findings of each type. Let's start with prerenal azotemia. This is due to a decreased blood flow to the kidneys, such as in heart failure or hypotension. Now, NSAIDs can be dangerous in these circumstances because they inhibit prostaglandin production, which leads to decreased renal blood flow. So here's an image of the nephron, and we're going to focus first on the glomerulus. Down below, we can see endothelial cells, indicating that we're dealing with the arterial supply. And this one right here, entering the glomerulus, is the afferent arteriole. Now, prostaglandins normally dilate the afferent arteriole, so let me clear this up. We'll draw arrows outward to indicate this dilation. And again, prostaglandins do this. And as a result of this action, there's increased blood flow. Now, patients with intravascular volume depletion, for example, in heart failure or excessive diuresis, they're dependent on those prostaglandins to preserve blood flow to the kidneys. Now, NSAIDs will decrease prostaglandin production, which can severely decrease blood flow to the kidneys. And that can then cause prerenal azotemia. Now let's discuss lab findings. Remember from the first slide that acute kidney injury occurs because of an abrupt decline in renal function. So there will be low GFR and a high serum creatinine. And that's in all of these categories, including prerenal injury. Now here on this table, we're going to discuss labs that help you figure out which type of acute kidney injury you're dealing with. Prerenal azotemia presents with a serum blood urea nitrogen, BUN, over creatinine, so BUN to creatinine ratio, greater than 15. Let me show you why on a new slide. This is the lumen of the filtrate, so just picture the proximal tubule here, and we'll have the serum over here. Imagine urine gets filtered from the glomerulus and down into the tubule, and the solutes that enter the filtrate can be reabsorbed. And again, that's back into the serum. Now, some of the solutes can be BUN and creatinine. Now, BUN normally gets reabsorbed by the tubules to some degree, but creatinine does not. Again, this is normally what happens. The net effect of creatinine not being reabsorbed and BUN being reabsorbed means that the BUN to creatinine ratio in the serum is about 15. But what happens in prerenal azotemia? Well, remember that acute kidney injury means the kidneys aren't working as normal, so things like serum creatinine and BUN will increase. Now, in prerenal causes specifically, you need to think about the fact that the kidney isn't getting perfused as normal. You may recall from our renal physiology chapter that if there's decreased blood flow to the kidney, renin will be released, engaging the renin-angiotensin-aldosterone system. This ultimately causes the renal tubules to reabsorb even more substances, including urea or blood urea nitrogen. However, creatinine doesn't get reabsorbed. So serum BUN levels are even higher. So if we go back up to the BUN to creatinine ratio, I'll draw a second arrow by BUN. So in this situation, the BUN to creatinine ratio will rise above 15. Now, prerenal azotemia also presents with a fractional excretion of sodium less than 1%. Let me show you why. FENa stands for fractional excretion of sodium. The numerator is milligrams of sodium in the urine, or excreted sodium, and the denominator is milligrams of sodium that's filtered by the glomerulus. Remember from physiology that blood is filtered first by the glomerulus, and filtration is represented by this top white arrow. Now, most of the sodium that gets filtered ends up being reabsorbed, and this occurs in the peritubular capillaries. So that's represented by this white arrow. Now, any sodium that does not get reabsorbed will be excreted, as written right here. Now, we just mentioned that in prerenal azotemia, sodium is reabsorbed as normal. This means very little sodium is excreted. So let's say that 100 milligrams of sodium is filtered. 99 milligrams of that sodium is reabsorbed, while only 1 milligram of sodium is excreted. Putting that in the equation, we have 1 milligram of excreted sodium divided by 100 milligrams of filtered sodium. So the fractional excretion of sodium is 1%. I'll write this in the top right corner, and that's the FENa. Again, this is normal and what you'd expect in prerenal azotemia. To be more precise, normal fractional excretion of sodium is less than 1%. So I'll emphasize that with a less than sign here. So the take-home point is that you should assume over 99% of sodium is reabsorbed in the tubules. Now, this equation is discussed in more detail in our nephrology physiology chapter. Lastly, prerenal azotemia presents with a urine osmolality greater than 500, specifically greater than 500 milliosmoles per kilogram. Urine osmolality is a measure of the concentration of solutes in the urine. Large values indicate concentrated urine, and small values indicate diluted urine. Now, if water is reabsorbed at a higher rate as a result of the renin-angiotensin-aldosterone system being activated, then more water will be reabsorbed, which will concentrate the urine, meaning the urine osmolality will be high. Now let's move on to intrinsic azotemia. In this type, the problem is within the nephron somewhere. So it's a problem pertaining to the intrinsic function of the kidney. And intrinsic acute kidney injury should be broken down into two groups, those that cause tubular damage and issues that cause glomerular damage. Let's focus on tubular damage first. The primary causes here are acute tubular necrosis and acute interstitial nephritis. Acute tubular necrosis occurs when there's toxin-mediated damage or ischemic damage to the proximal convoluted tubule. Now, the PCT is especially susceptible to things like toxins and ischemia, which is why we're pointing out that it's the PCT here that gets injured. And now we're going to look at the same labs as with prerenal injury: urine osmolality, fractional excretion of sodium, and serum BUN to creatinine ratio. To understand why tubular damage will cause these particular lab findings, you just need to think about the role of the tubules. If the tubules aren't working, then the nephron isn't reabsorbing substances as it should. So the serum BUN to creatinine ratio will be less than 15, and the fractional excretion of sodium will be greater than 2%, and the urine osmolality will be less than 350. Let's make it super clear why this occurs. Just like before, acute kidney injury causes the serum BUN and creatinine to both increase. However, intrinsic acute kidney injury, more specifically tubular intrinsic injury, means the tubules are damaged, so they can't reabsorb. So I'll erase this reabsorption line from BUN. And if some BUN is normally reabsorbed, but now it's not, then serum BUN will rise, but not as much as it would if the tubules were working. So this makes the serum BUN to creatinine ratio less than 15. So less than normal. And just to help illustrate my point, I'm going to make the increase in BUN a smaller up arrow. Now let's talk about the fractional excretion of sodium. Why would that increase? Well, since the tubules are unable to reabsorb properly, substances like sodium are lost in the urine. And remember that the equation for fractional excretion of sodium is excreted sodium, or sodium that's measured in the urine, over the serum sodium, or filtered sodium. And if less sodium is reabsorbed, a urinalysis will show increased sodium in the urine. So the fractional excretion of sodium is greater than 2%. And also looking at this tubule, if the tubules aren't working and they can't reabsorb water, then that means more water will be in the urine. And if water can't be pulled out of the filtrate, then it will remain in the urine and dilute it. Another way to say this is that tubular damage prevents the kidneys from being able to concentrate the urine. So the urine osmolality will be lower, or diluted, and will be less than 350 milliosmoles per kilogram. This image demonstrates acute tubular necrosis. You can see the glomerulus here and tubules here. There's actually many tubules throughout. You can identify a necrotic tubular cell as those that lack nuclei, and you can see some nuclei here. However, many of the tubular cells lack nuclei, indicating necrosis, and these necrotic cells will slough off and enter the lumen of the tubule, as you can see here, and then they form a cast, which can then be seen on urinalysis. So we discussed serum BUN to creatinine ratio, fractional excretion, and urine osmolality, and this applies to both acute tubular necrosis and acute interstitial nephritis. However, those casts that we discussed over here on the previous image are from tubular cells dying, as I just described, and they end up having this brown granular appearance. So the detail about brown granular casts applies only to acute tubular necrosis. In a moment, we're going to discuss the specifics of acute interstitial nephritis. But before we do, there's something else you need to know about acute tubular necrosis. And it's the fact that it has stages. The first stage is the inciting event, and that may last up to 24 to 36 hours. During this stage, there's only a slight decrease in urine output. Now the next stage is the maintenance phase, which can last 1 to 3 weeks. This is the oliguric phase. During this phase, there's risk of hyperkalemia, metabolic acidosis, and uremia. And that's due to the significantly decreased urine output, so potassium, acids, and urea will stay high in the blood. The last stage is the recovery phase. In this stage, the GFR will actually improve, even though the tubules really aren't able to reabsorb properly yet. This means that the kidneys still can't concentrate the urine. This leads to polyuria, hypokalemia, and renal wasting of other electrolytes and minerals. Later in the stage, there's re-epithelialization of the tubules. And once this happens, then the kidneys can return to normal functioning capacity. But I want to quickly make sense of the fact that GFR is improving, but the patients still experience polyuria and hypokalemia. Going back to this image, remember that the tubule cells will die and they'll slough off into the lumen. And when they do, they're going to form casts. That causes obstruction and decreased GFR. But in the recovery phase, these casts aren't there to obstruct anymore. So the patients can get a normal GFR, but the tubules still aren't working. So there's just lots of waste, so polyuria, and excess loss of potassium, so hypokalemia. Let's try a question to apply what you've learned. A hypovolemic patient has prerenal azotemia. Urinalysis reveals brown appearing casts. How did the prerenal condition lead to the formation of these casts? So the brown casts should make you think of acute tubular necrosis. This necrosis, caused by tubular cells, slough off into the tubular lumen and form these brown casts. However, the patient had a prerenal condition. So why do they now have acute tubular necrosis, which is an intrinsic problem? Well, remember that prerenal azotemia means there's decreased perfusion to the kidney. And what are the two causes of acute tubular necrosis? Toxins and ischemic injury. So in this patient, the prerenal condition must have gone on long enough that it led to ischemic damage. And that answers our question. The prerenal condition continued on long enough that ischemic injury occurred, and the tubular cells experienced necrosis. So the patient had acute tubular necrosis. Now going back to the table, just keep this underlying pathology in the back of your mind. Prerenal conditions are marked by decreased blood flow, which can lead to ischemic damage, causing acute tubular necrosis. Now let's discuss the details pertaining to acute interstitial nephritis. Acute interstitial nephritis is basically leukocyte infiltration of the interstitium and damages the tubules. So basically, it's a hypersensitivity reaction or an allergic reaction. Now this hypersensitivity reaction can be caused by drugs or a systemic condition. Some drugs are NSAIDs, penicillin, diuretics, proton pump inhibitors, rifampin, and sulfonamides. The list is basically endless. Now this typically happens when the patient starts a new medication, and they'll sometimes get a rash and a fever before developing acute kidney injury. As I mentioned before, acute interstitial nephritis may be caused by systemic conditions, and what you should be thinking about here are infections, such as mycoplasma, and autoimmune conditions, such as lupus or sarcoidosis or Sjogren's syndrome. In these conditions, autoantibody formation results, and the patient ends up getting a hypersensitivity reaction. Regardless of the exact cause, all of these different causes involve a hypersensitivity reaction, and that results in leukocyte infiltration of the interstitium and damages the tubules. Let's go back to this image briefly. Here's the interstitium, and these patients, because they have a hypersensitivity reaction, get white blood cells or leukocytes infiltrating the interstitium, causing lots of damage. And we especially care about this because this damage ends up including tubules as well. Now, it's important to know that some of these white blood cells are eosinophils, and they actually end up entering the lumen of the tubules, and so they can be excreted. So, eosinophiluria. Likewise, you'll also get white blood cells that just enter the lumen and form a cast. So, on your analysis, you can see white blood cell casts. Now, here's a micrograph of acute interstitial nephritis. Here are the tubules, and we can even see the glomerulus. The interstitium is all this stuff, everything between them. And you can see leukocyte infiltration throughout this interstitium. And some of those leukocytes are even entering the tubule and damaging that. So going back to the table, acute interstitial nephritis can result in eosinophiluria and white blood cell casts. And that's in addition to these other lab findings that are common to all intrinsic tubular damage injuries, like acute tubular necrosis. Let's try another question. A 70-year-old woman with a history of hypertension, diabetes, and osteoarthritis presents to the emergency department with periorbital edema, a maculopapular rash on her chest, and fever. She also reports decreased urine output. Urinalysis shows mild proteinuria and eosinophils. Based on these findings, does this patient more likely have acute interstitial nephritis or acute tubular necrosis? So the details that you want to think about here in this patient are the maculopapular rash on her chest and her fever, as well as her decreased urine output. Now, this decreased urine output, or oliguria, makes us think of the possibility of acute kidney injury. And the rash on her chest and the fever make a hypersensitivity reaction a likely cause of the acute kidney injury. But the dead giveaway for a hypersensitivity reaction is the eosinophils in her urine. So we're pretty confident that this is a hypersensitivity reaction, and this is acute interstitial nephritis. And we're not thinking about acute tubular necrosis because those patients would have brown granular casts. They wouldn't have eosinophils in the urine. So again, acute interstitial nephritis is more likely than acute tubular necrosis. Okay, let's move on to intrinsic renal failure that results from glomerular damage. This can be caused by numerous conditions that involve the glomerulus. Acute glomerulonephritis is the name we give to this category. Now, going back to this image, we see the intrinsic functional unit of the kidney, the nephron. But instead of tubular damage, we're focused on glomerular damage. Glomerular diseases present quite differently than tubular diseases. When the filtration barrier in the glomerulus doesn't work correctly, it actually allows certain substances to enter the filtrate when they should not. For example, protein and red blood cells. So naturally, this results in protein and red blood cells in the urine, so hematuria and proteinuria. So on lab findings for acute glomerulonephritis, you get hematuria and proteinuria. And normally, when cells enter the filtrate, which they're not supposed to do, they'll clump together and form casts. And you can see those on urinalysis. And that's the case with acute glomerulonephritis. You can visualize these RBC casts. Now, what about the BUN to creatinine ratio, or the fractional excretion of sodium, or the urine osmolality? Well, the tubules are working, right? It's only the glomerulus that's having problems. So you would expect urinalysis to produce findings similar to prerenal azotemia. So a BUN to creatinine ratio greater than 15, a fractional excretion of sodium less than 1%, and a urine osmolality greater than 500. Lastly, notice that I've written here if acute kidney injury is present. I really want to emphasize this point. I put this here because I want you to know that glomerular diseases don't always cause acute kidney injury, whereas they basically always cause hematuria and proteinuria. Now, later in sections 3 and 4 of this chapter, we discuss nephrotic and nephritic syndromes, and some of those can involve acute glomerulonephritis and can sometimes lead to acute kidney injury. Now, all the details of those conditions will be discussed there, and I included this row here on intrinsic glomerular damage resulting in acute kidney injury, so that when you learn that some nephritic and nephrotic syndromes can cause acute kidney injury, you will know how it fits into this acute kidney injury framework. It's an intrinsic azotemia. Okay, let's move on to postrenal azotemia, which is basically a urinary tract obstruction. And this obstruction can be anything downstream of the kidney. For example, obstruction of the ureter, prostate, bladder, or anything that would prevent outflow. Now, early on in problems like this, the nephron is still able to reabsorb solutes from the filtrate, and it's able to concentrate the urine. So the lab findings are similar to those seen in prerenal azotemia. So BUN to creatinine ratio greater than 15, fractional excretion less than 1%, and urine osmolality greater than 500. And again, that's early. If the patient's condition isn't treated, then the high pressure in the renal tubules, because of that obstruction causing backed up pressure, then the tubules will eventually get damaged. So that means that the lab findings later in this disease will resemble those of intrinsic tubular damage injuries. So fractional excretion of sodium will be greater than 2%, BUN to creatinine ratio is less than 15, and urine osmolality is less than 350, indicating dilute urine. Or you could say that the nephron is unable to concentrate the urine. Now, the reality though, these labs aren't the best way to determine if the patient has postrenal injury. The more practical approach is just looking at the patient and determining if they have issues that would cause obstruction. And then you visualize that obstruction by performing a renal ultrasound. Let me illustrate these pathologies on a new slide. Here's a picture showing some of the possible conditions that could lead to postrenal azotemia. The best way to think of the various causes of postrenal azotemia is to think of these different organs: kidney, ureter, bladder, and prostate. In the kidney, there can be calculi or tumors, and these can block urine outflow, especially if they're bilateral. So you're mainly thinking of the renal pelvis. In the ureter, nephrolithiasis or kidney stones can block urine outflow, especially if bilateral. And in the bladder, there can be urinary retention, which will lead to decreased urinary outflow. And this urinary retention can even be neurogenic. For example, a patient just coming out of anesthesia. In that case, you're not expecting the patient to have an obstruction when you do the renal ultrasound. Instead, you'll expect the anesthesia to wear off, and the patient will eventually be able to excrete urine as normal. Now, in the prostate, you can think of benign prostatic hyperplasia or even prostatic carcinoma. And naturally, either of those can cause obstruction. So the workup in patients like this will likely be directed towards some symptoms like pain, and that would point to an obstruction. For example, colicky pain from kidney stones. Or leading up to their acute kidney injury, the patient will have abnormal urinary symptoms that result from things like prostatic hyperplasia. For example, they might have increased urinary frequency. And with that understanding, the clinician will find the obstruction using ultrasound, and that will help the patient fix the issue. Let's try another question. A 62-year-old man presents with a 2-day history of shortness of breath. His blood pressure is 73/53. Physical examination reveals bilateral jugular vein distension and pitting edema. Laboratory studies include the following: a BUN of 60, a creatinine of 3, glucose of 100, and a sodium of 137. Now, is the underlying pathology in this patient more likely prerenal or postrenal? So the symptoms the patient demonstrated, low blood pressure, pitting edema, jugular vein distension, and shortness of breath, all indicate likely congestive heart failure. And laboratory studies show a BUN of 60 milligrams per deciliter and creatinine of 3. So what's the BUN to creatinine ratio? Well, that would be 60 divided by 3, which is 20, which is greater than 15, so greater than normal. So the tubules in this patient are likely functioning, because you wouldn't expect a BUN to increase more than creatinine unless the tubules were reabsorbing more BUN than usual. So tubules are functioning. And when the tubules are functioning, we would expect prerenal azotemia and postrenal azotemia. So the BUN to creatinine ratio doesn't tell us whether or not it's a prerenal condition or an early postrenal condition. But the clinical symptoms tell us what's going on. The patient has CHF. And recall that the pathophysiology of prerenal azotemia is decreased blood flow to the kidneys, leading to decreased GFR, oliguria, and azotemia. And congestive heart failure can cause that decreased renal blood flow. So the correct answer is that this is more likely a prerenal condition. Now let's briefly discuss renal papillary necrosis. As the name suggests, renal papillary necrosis is necrosis of renal papillae. This presents with gross hematuria and flank pain. The renal papillae receive their blood supply from tiny arteries that are highly susceptible to ischemia. Eventually, this ischemia leads to necrosis, which causes those necrotic cells to slough out and lead to hematuria. Causes of ischemia and necrosis of the renal papillae include diabetes mellitus, chronic analgesic abuse, sickle cell trait or disease, and severe acute pyelonephritis. Now, diabetes mellitus can lead to hyaline arteriosclerosis, which narrows the blood vessels leading to ischemia. Chronic analgesic abuse causes ischemia by inhibiting prostaglandin release, which causes vasoconstriction. And then sickle cell disease, or trait, causes sickled RBCs to obstruct the small vessels of the kidney, which predispose those vessels to ischemia. And in severe acute pyelonephritis, the fibrotic interstitial and atrophic tubules of the pyelonephritic kidney compresses the medullary vasculature, which leads to ischemia. Again, that's severe cases of acute pyelonephritis. Now, the papillae are the tips of these pyramids, and they're susceptible to ischemic damage and can experience necrosis. And again, this necrosis results in hematuria, as the RBCs are able to enter the renal pelvis and then be excreted with the urine. And again, this presents with flank pain. Now that we've covered all the information, let's review with a question. 48-year-old woman presents with chest pain. Physical examination reveals low blood pressure, cool extremities, and elevated jugular venous pressure. Her urine output is decreased. Urine microscopy reveals brown granular casts. Which of the following lab findings supports a diagnosis of acute tubular necrosis? A. Fractional sodium excretion equals 0.5%. B. Serum BUN to creatinine ratio is 16. C. Urine osmolality is 250 milliosmoles per kilogram of water. Or D. Eosinophils in urine. Now, based on the chest pain, low blood pressure, and the cool extremities, and the elevated jugular venous pressure, it appears that the patient has prerenal azotemia as a result of congestive heart failure. But we're also told that urine microscopy reveals brown granular casts, which is a finding of acute tubular necrosis. And that's a cause of intrinsic azotemia. So this is similar to the question before, where there's a prerenal condition that goes on long enough that leads to ischemic injury and acute tubular necrosis. So we're not expecting this to be prerenal. So now we just need to remember what are the lab findings that we would expect with acute tubular necrosis, and then we can answer the question. We can see that intrinsic azotemia usually presents with a BUN to creatinine ratio less than 15, fractional excretion of sodium greater than 2%, and a urine osmolality less than 350, all of which indicates that the tubules aren't working. So the correct answer is C, urine osmolality of 250 milliosmoles per kilogram of water. A is incorrect because a fractional excretion of sodium of 0.5%, which is less than 1%, would be more indicative of a prerenal condition. But again, given the brown granular casts, the patient most likely has intrinsic azotemia and acute tubular necrosis. B is incorrect by similar logic. It's 16, and we would expect it to be less than that because the tubules aren't reabsorbing BUN as much. And D is incorrect because eosinophils are found in the urine in acute interstitial nephritis, which is another cause of intrinsic azotemia. And that condition would likely present with fever, rash, even white blood cell casts in the urine, and the patient may have a recent history of starting a new drug. So again, C is the correct answer. And that concludes this section.